great. Well, today we'll kick off our second week of our Global Child Health Lecture Series, and we have two amazing speakers who are joining us all the way from Malawi. So we really appreciate your time, and as I said, extending your workday to be with us. Amy Connolly and Chisomo Kondowe are work with Partners in Health in Neno District, and today they'll be telling us about implementation of a pediatric development clinic in rural Malawi. I'll let you guys go ahead and take it away.
Wonderful. Thank you so much, Teresa. And thank you so much for having us today, everyone. We're honored to be here. I just wanted to quickly go through and then we'll give our introductions. We're just going to give the presentation around our introductions and motivations, a little bit of the background around some thoughts that we wanted to share in child health. Then we'll give some updates and sort of information around what we call the PDC, or Pediatric Development Clinic, and the care delivery that's in Malawi, where we work, and then also sort of now the next steps of learning from it and advocating for replication of some of these services in Malawi. So just as a quick introduction, motivation, thank you so much again for the introduction. Just as a quick background for myself, I'm a pediatrician. And actually did the HEAL Fellowship through UCSF in 2015 to 2017, and then really have been in Malawi since then. I served as the Chief Medical Officer for several years for Partners in Health in Malawi, and now I'm actually seconded to the National Ministry of Health, where I do much more sort of national implementation and policy work, but still do clinical work as a pediatrician and help out where I can in the Pediatric Development Clinic. So you'll see sort of both sides of that today, of the direct care delivery and then also some of the sort of replication of learnings that we can be working on. So I'll just pass it over to Chisomo quickly to give her introductions and her role in the clinic as well. Thank you, Chisomo.
Thank you, Dr. Emi. I'm Chisomo Kondowe. I have been working as the Pediatric Development Nurse Mentor. I have a degree in health systems management and then a master's in public health. And I've just been promoted. I'm currently now working as the primary health care manager, but I still love and I see that Pediatric Development Clinic is our baby, and we really want to see it grow further than to how it is. Thank you very much for having us.
Great, thank you again. So I think I'm going to get us started, and then Chisomo will come in with some more information on the PDC. So let's see, how can I move this? Oh no. There we go, apologies. So just to give, I think everyone likely knows a lot of these stats. But I think just thinking about the child health landscape more globally, and then a little bit more specifically in Malawi as we move forward, there's really been significant drops, as we all know, in neonatal mortality and under 5 mortality in the last 20 to 30 years. And it's been a real significant area for development and also for health for children. However, I think we all know that neonatal mortality rates are the hardest to really decrease, because it takes such an effort of the life course of the mother, and then also so many acute care needs at the delivery, and how can these sort of services be given to all mothers throughout the world. And a lot of because many of the countries in sub-Saharan Africa, like Malawi, lack, especially some of these emergency services. We can see that the vast majority of newborn deaths occur in sub-Saharan Africa as a proportion of the global newborn deaths. Most of these deaths are in the first 3 days of life, again, sort of alluding back to the need for emergency and sort of acute care. But there's also some pretty significant post-discharge mortality that we've also seen in working within Neno District, what we'll get to in the next few slides. This also results in some of these small and sick infants, so those with prematurity, birth asphyxia, hypoxic, ischemic encephalopathy, they fail to reach their developmental and health and nutritional potential. It's compounded by the lack of care access and poverty and malnutrition. We see that, even in more high-income countries like the UK or the US, but we know that sort of all of these low resources also affect some of their ability to thrive. And one major area in Malawi is the care access. And so that's sort of where we're really heading to at the moment. This is always, I think, just a really interesting slide to point out. This graph, which is freely available, on the World Bank website, shows child mortality, if you can see my pointer, on the right-hand side, and then the current health expenditure per capita. That's on the bottom part of the graph. You can see the United States, as we all know, has really high expenditures for health, between $11,000 and $12,000 per person a year. And then here is Malawi, which spends, depending on, again, the source, between $45 and $55 per person per year. Now, looking at the child mortality in Malawi, it's just below 4%. And in the United States, it's just around 2.5%. I think that it's obvious that you can see from my last point that many of these countries up here in the sort of higher left-hand side have lower health expenditures, and therefore their neonatal and child mortalities are higher. But you can see that in this middle area, there's many countries that spend less on healthcare and still have lower childhood mortality than the United States. So I think we're just wanting to look at this not just as a picture of resources, or not everyone with less resources than maybe some of these very high income countries can eliminate child mortality. And it has a lot to do around health equity and social justice and poverty and sort of circumstance. So just looking a little bit further into the child health landscape in Malawi, for anyone who hasn't been here or seen the country before, it's in the sort of southeastern corner of Africa, and is home to about 19.5 million people. A significant proportion of this population is children and youth. And so therefore, again, it's a really important area to be thinking about child health. And then a significant proportion of that population also lives in very rural areas and doesn't have as much access, especially to emergency and critical care services at sort of higher level hospitals. You can see that the neonatal mortality rate has decreased significantly, and we'll actually look at this in a graph on the next slide. And there's been a lot of work, through the government, by funders, to really try to improve maternal and neonatal access to care by making more facilities and also increasing the number of births that are attended by a healthcare worker. Children after birth have immunization, growth monitoring, and supplementation visits, but no true sort of child care in a coordinated way, which we'll go into in a little bit further. That also doesn't include regular developmental monitoring. So this graph just sort of shows the challenges also in childhood and neonatal mortality. This one I'm just putting infant and neonatal mortality on, but you can also see this in maternal mortality, child mortality. It sort of works in all of them. Most significantly, I would say, in neonatal mortality. But looking at the graph on the left-hand side is the number, the rates, the neonatal or the infant mortality rate, and then on the bottom is the years. So, and it's comparing the births that are attended by skilled health staff, or really the ones that are in a facility, the deliveries that are in a facility, compared to the mortality rate. And you can see, starting from 2000, there's been a doubled increase in the babies who are born in the facility and attended by a skilled health staff. And now it's almost close to 100%. Malawi has been very, very successful at improving facility deliveries. You can see that this intervention, along with several others, has really dramatically decreased infant and neonatal mortality. But in the last decade, especially, there's been a slowing down of those decreases and sort of flattening of the curve. So it just shows that despite all the babies being born in a facility, perhaps some of those facilities are not resourced in the way that they need to be. Perhaps there's not the right training for the healthcare staff. Perhaps there's not the right infrastructure, medications, et cetera. And there needs to be further intervention. So it's important to always sort of keep this in mind and be thinking now, how do we improve the quality of that care, the resources that are available? So just to sort of go back a little bit in time and thinking about, how did we get to this place in child health? And I think this is true for a lot of primary healthcare interventions as well. There was the Alma Ata Declaration in 1978 that really focused on improving health for all people through the pursuit of primary healthcare for all. And this was really linked to a universal healthcare approach, which I think most of us, have heard about. However, this was also linked directly with an economic downturn. And so implementing, holistic primary healthcare for all really was a challenge during this time. And I think, of course, that this has extended into the current time as well. There's a lot of stress of making sure that only cost effectiveness interventions were funded at that time, which most of the way that you can build out a cost effectiveness argument is through one specific disease or one specific activity. So this led to a lot of what we call vertical disease programs, or only looking at, respiratory disease for a child or diarrheal disease. And there was much less funding for looking at more community participation or looking at sort of the child over its life course, and really thinking through also the social justice and equity approaches of making sure that all children, especially those living in poverty or with vulnerable pieces like prematurity or birth asphyxia, had access to these services. So that has really resulted in what is called selective primary healthcare for children. So there's several programs that have developed from this sort of funding flows, and many of which I'm sure you've heard of in terms of the expanded immunization program. So children come for immunizations. They also will come for growth monitoring and nutrition. Sometimes that's linked to immunization, depending on the country. And then if they're sick, mostly diarrheal diseases or respiratory, they can come to the facility for what's called IMCI, or Integrated Management of Childhood Illness. And then on top of that, there's mass drug and micronutrient administration, but often these services are not necessarily put together, and there's not sort of additional well-child services that are integrated into this. So that's really a picture, hopefully explaining a bit more of exactly really where Malawi stands at the moment for child health. However, in the recent history, there has been a real push for service delivery reform. This is through the National Health Sector Strategic Plan. And there's recognition that some of this more vertical disease implementation, like just immunizations, just growth monitoring, is really not very patient-centered and leads to a lot of fragmentation of services and duplications. The parents have to come back for growth monitoring, they have to come back for immunizations. And so there's been a re-looking at the healthcare system to try to imagine what the Alma Ata Declaration would look like. So instead of looking at these sort of more specific diseases like tuberculosis, NCDs, which are non-communicable disease like sickle cell, anemia, or asthma, or hydrocephalus, congenital abnormalities, separate from maternal child health, it's more about how do we put together all of the different things that need to happen at each level of care, this one being primary care, and better understand what types of health education need to be given for all the different diseases, what kind of screening for disease is needed for different types of patients, diagnosis, treatment, and patient support. So really lending a hand to trying to look at the patient as a whole and what they need to be in their highest health at all times. So just to give you a little introduction to Partners in Health, in case perhaps you haven't heard of it, Partners in Health is a non-governmental organization that's been for a long time. Its sort of headquarters coordination has been in Boston in the United States, but also has several sites, as you can see on the map, around the world, one of which is in Malawi, where we work. And the mission is really looking at comprehensive care models that look beyond just perhaps your typical healthcare, but how to really support the entire patient to be able to live a productive and high quality of life, and making sure that we're bringing the benefits of any program, medication, activity that could improve people's health to those who are the most vulnerable and living in poverty. So just to give you a close-up, I think we showed you Malawi a few slides ago, but the main site that Partners in Health works in is called the Neno District, which is down here in the sort of southwestern corner. And you can see here that there's several different health facilities, 2 hospitals. It's sort of split right down the middle here, if you can see my arrow, right in sort of the middle of the district, by a sort of more mountainous area on the upward side and a more sort of dry Rift Valley lowlands area on the right-hand side. So transport is quite challenging, and there can be very long distances to get in between some of the hospitals and the facilities, which is true for most of Malawi. Partners in Health works in what we call a theory of change that really starts with clinical care delivery. So how can we help the ministries of health really deliver high quality care? And then how can this lead into improvements in training capacity of staff throughout the healthcare system and even beyond in a very multidisciplinary approach? And then bringing that experience of care delivery and training to influence other, places within the country or even out of the country, and trying to bring some of that learning to influence national policy and implementation, especially with the social justice approach. And then that sort of leads into replication of that approach. So we'll come back to this in terms of the Pediatric Development Clinic after Chisomo reviews the Pediatric Development Clinic and some of the amazing work that she does with many colleagues. So I'll turn it over to you. Oh, no, I have one more slide. Sorry. So before Chisomo comes in, I just wanted to paint the picture in Neno District. I think many of the same statistics hold very true to Neno, except that there has been more difficulties in accessing care because of the terrain and the geography. But back in 2016, myself and several others were the first to be able to start a neonatal nursery that helped many children with asphyxia, prematurity, low birth weight, and sepsis as like sort of the 4 most common diagnoses at the district hospital, which is about the center of the district. However, because we were successful at finding more babies that had these complications, which you can see here at the bottom, you can see many of them were quite low in 2013, but a lot of that was due to the fact they weren't being counted or diagnosed. And as we've gone through the years, we have a much more representative sample for what would be expected for the population, and also have been able to decrease sepsis, especially. We would love to have decreased asphyxia more, and that is definitely a quality improvement project going on currently. But we're saving more babies, and so there's more babies who have developmental and well child care needs in the district. And so that was really the point of creating a well child, a developmental clinic, to make sure that we could take care of these babies once they were discharged from the nursery. But there still exists a lot of low resources for the continuity of care, such as hearing or hearing screening that doesn't exist in the district. So then there does have to be referrals outside. So there's still work to be done that Chisomo will go through in the next slides. Just let me know when to change the slides, Chisomo.
Thank you, Dr. Emi. Thank you everyone for joining us. Yes, I'm going to present from this point on what we do in the PDC and what is our current statistics, mostly on as the work is being done. Next slide, please. So taking on from the previous slide that Dr. Amy had shared about the influx of numbers in various children conditions. So here is one of the scenarios that we can present to you about a child, a baby who's born from a teenage mother and has a very poor APGAR score at 1 minute, 5 minutes, and then 6 minutes. 10 minutes, and then this child eventually is admitted into the NIC unit because it has seizures and has to be put on oxygen and then being fed through an NGT. Now, when this child is discharged, what next? What will happen to this child when they go home? So that's when PDC comes in such scenarios as these. Next slide, please. So basically in PDC, our goal is to look at vulnerable newborns under 5, basically, any child with an issue of developmental delay. And basically they are receiving care and intervention during this critical developmental period. And we look at all the aspects of life. We look at their physical, we look at their social, we look at their developmental. Socially, we look at how we can support them with finances and the other foodstuffs. And the development, we want to ensure that the child reaches the maximum it can attain, though there are these complications that the child was born with or along the path to development they came in. So we have children who are born with high-risk conditions, but our challenge is that we only manage them up to 5 years. Once they reach 5 years, we have to discharge them from the program. So we look at these main aspects of every child: the physical, their cognitive, their social, and the emotional development. So we move on the path with these children throughout, from time they are born. If they do well, we discharge, but otherwise would move with them until they reach the age of 5. Next slide. So when did we start PDC? We started actually in 2021. This is a replica program that is already currently running in Rwanda. We were able to get support from Rwanda to develop interventions that would fit our setting and even like documents, programs that we could put into PDC so that we take it forward. But currently the challenge we have is we have to share space with what we call the NCD clinic, and we have limited in nurses and medication and other stuff, but we have nurses who are running the program. We get medication, we have physiotherapy teams, and we are able to integrate ourselves into what we call the IC3. So on the right side, you can see our actual flow, how these children come into the clinic. They are referred first of all, and then we as the nurses in the clinic do the screening, and then we have the general counseling for the parent and education. We do the clinical review because each child, we always want to look at each child as an individual from the other. And then if they need other support, then that's when the physiotherapy or physical support comes in. But almost all our children, they end up receiving social support, but the psychological support is never ruled out. Because if you look at children with delayed issues, they are mostly stigmatized in the community, or the parents are actually discriminated against because they have a child with some developmental issues. So we have been running from 2021, and currently we are still running, and we are doing quite well. Next slide. We have a specific flow for our clinic. It does not matter where the child has been referred from, but when they are referred to us, we are the nurses. We, the nurses, are the ones who are responsible for screening for admission. Does the child fit the criteria that has been established or set aside in the clinic? And if the child fits the criteria, they go through what we call an enrollment process. And once they're enrolled in the clinic, we give them a follow-up date. Basically, the follow-up date differs from condition to condition because there are some which have to come every 2 weeks. There are some which usually would come for the first follow-up after a month of enrollment into the clinic. Then at that first follow-up, that's when we determine whether the child should have a developmental assessment, which we use the Malawi Development Assessment tool. It actually it's actually divided into sections where we start from 3 months, 6 months, 9 months, and then at 1 year. So at all those stages, would actually do a developmental assessment for these kids. And once they are okay or there are no challenges, then we continue following up depending on how well the child is doing in relation to the condition. But if there's a challenge, then there are other measures that are put in place to ensure that the child is followed up more than any other child, because we feel that we should always give each child individualized care depending on their program. So when they reach when the child has actually improved, has attained developmental milestones, if it was another condition or the child had malnutrition, is now free from malnutrition, but we never leave out the attainment of developmental milestones in every child, no matter what the condition was, and then would actually discharge. But if they've not been able to attain at 1 year, 2 years, we'll still keep the child in the program until they reach 5 years. Now from 5 years, that's when we determine the next step of action. Where do we continue this child to be in? Which program should the child continue to be in order to be supported despite being discharged from PDC? Why 5 years? Because of limitation of resources in our department. So we'd always say, let's look at them for these 5 years and then discharge. Next slide, Dr. Emi. So we have all these arms that we follow in our clinic. After enrollment, each child has to go through nutritional screening. You know, most of the children in Africa, even in Malawi, especially in Neno, because of the dryness and then the terrain and then the difficulties and all those challenges, would have to do a nutritional screening to rule out malnutrition. And if the child doesn't need, is okay, doesn't need nutritional support, would have to go for clinical review. As I had said, we are working in the IC3, and that's where we have all these advanced conditions. We have those children with sickle cell, those children with heart challenges, those children with hydrocephalus. Any child that needs clinical review would have to go that, and then we do the developmental assessment. So depending on the need, supported with the several arms, but in our clinic always go for psychosocial counseling. And then if the child has developmental issues, physiotherapy, and then they are referred for more special services, which are currently not available in Neno. We'd have to refer out to our tertiary facility, and that's also another cost. So basically, we have children who are HIV positive, children who had TB, and all of those, they are actually put in specialized services where they are actually co-managed with us as PDC. You can go forward, Dr. Next slide. Okay, thank you. Since we started the program until July 2024, we have actually surpassed our target. We had initially planned to enroll 300 children by 3 years, and we have actually surpassed that target, which is actually a clear indicator that we really have these issues in our setting. And as you can see from the breakdown in the table, how the age disaggregation for each of the condition, and mostly we have been struggling with birth asphyxia, which is usually HIE, and then it is followed by those children who are born preterm, low birth weight, and then we had epilepsy, developmental delay, some genetic abnormalities, and others. Others would usually follow in the category of malnutrition, So we have those nervous infection and any other condition that actually follow in that. And then when you look at the proportion of the programs that we are actually working in, the social support is actually paramount and carrying a lot of the percentage in how we are supporting, seconded by the feeding program, where we have to supplement with either infant formula or what we call SFP, which is actually the porridge component for children, and then we have the physiotherapy. And then the other specialized care is actually carrying a small portion, but these specialized cares are very expensive to get access to because there are so few in Malawi, but we've always managed to send children. And most of the specialized care that we have actually looked at is where we have the child has hearing problems, the child has speech problems, the child has eye problems, and the child has to get access to bed cure where they are supported with the operations for their limbs and other operations that are needed for the child. Yeah, so basically that's a breakdown of our ongoing patient profile for PDC. Next. Yeah, we've also seen the quality that is the quality of care, but in the quality of care, we've also had challenges. As I've said, we have limited resources. If you look at the graph on the right, where we have talked about how many patients are active, how many have defaulted, how many have been discharged, and how many have died. So you can actually see that we have quite a high number of children who are defaulting from the program. Keep in mind that this program is only in Neno currently in the district hospital. We are trying to decentralize it, bring it closer to the clients. So most of the clients have to travel long distances, and that's why they don't actually come back after some time. And when you look at the graph on the left, where we are talking about how many children who are currently in the program have been hospitalized because of other problems, other illnesses, you can actually see that we started quite small, but when we reached 2023, the graph actually went very high because of, remember we had these issues of Cyclone Fred, and then there was cholera, and then there were a lot of other illnesses that were currently on the ground in Malawi, and especially in Neno. So that actually increased the number of infants or children in PDC that were being admitted into the hospital. Yeah, we can move to the next slide. So we have always challenges, but the opportunities are also there. We've been able to have a strong primary healthcare system because of the integration of the chronic care. You know, we have a chronic care service where all the patients that are having NCDs are seeing HIV, TB. So because of that, it has actually boosted even our program of PDC. And children are discharged from the nursery. They are always linked, and because we have developed a relationship with the nursery, not only the nursery, but also the pediatric ward. So every child that they've understood to have a complication or may develop a complication related to the condition that they had are always referred to PDC. Our support system with the physiotherapy is so much in place that they are also have our full support, and we have their full support. And then we have strong community awareness. You know, previously as Partners in Health, we had a community health program where we had community health workers who were actually in the community, and these were actually linking us as PDC with the community, ensuring that every child that has not passed through the facility but is in the community, has developmental delay, has developmental challenges, were able to be connected to our PDC. So that link and that partnership is still there. But the challenge is we have no pediatrician in the district. We just use our fellow, we use clinicians, and we use doctors who are not specialized in pediatrics. I talked about long distance between the village and where care can be accessed, and then transportation is a big challenge, with especially during the rainy season. There are some opposing traditional beliefs and lack of knowledge. We currently are struggling with a large number of teenage mothers And then, you know, with the limited resources and all of that, it has actually led to a high number of children defaulting from the program, though they were benefiting, but because of limited resources, they can't travel long distance. All of that has actually led to a quite high number of default. And if we go to the next slide where we, Dr. Emilia, yeah, we're looking at what have we actually learned from the implementation of PDC, and moving forward, what can we actually continue to do? You know, previously people really in Neno, one thing that I discovered when I came to Neno, people did not like attending to pediatric Peds because they felt that children conditions are so difficult. But with the incoming of PDC, we have been able to impart skills in the management and the developmental issues of pediatrics. So basically, when you say I have a child, can you see this child for me? They actually come out and say, okay, what is the problem? Let's move forward with it. And it has proven that developmental issues can be managed in the midst of limited resources. If you look at the numbers that we have enrolled, they are quite high as per expectation. But so despite the limitations of resources, sharing a building and having not enough funds, but we were still able to support and manage developmental issues. We have seen how children have gained independence, and despite the challenges, we have had children who are discharged from the program. They are walking, they are able to talk, and all of that is actually happening. We've been able to start our decentralization process in the midst of limited resources, but we thought that the further we move, the closer we move to the client, the better we can really support them. And we have been able to use the data that we get from PDC in guiding some of the policies that we are actually being implemented. Because, I mean, we couldn't have a program without actually knowing what is happening and how it has been achieved. So the data has been quite a good, is very good in supporting us. And we really need to continue getting some of this data to enforce some of those policies that would really need, especially on child care. And then we've been able to have this multidisciplinary primary care with social support. So basically, we're not a standalone, but we're able to comprehensively manage and implement issues together with the support that we get, especially on the social aspect for our clients, our mothers, and our children in the PDC. So basically, when you look at this, we have those opportunities to continue with the program because it is a very good program that is being implemented. I don't know if I'm supposed to do the same. The next slide, can you just go forward? I think that's from you, Dr. Emi.
Great, thank you so much, Chisomo. Thank you for the overview. I think we just want to finish it up with a few slides showing some of what's happening now in Malawi, and then also how we're working to learn from the implementation of the Pediatric Development Clinic and advocate for some of these services to be also at national level. So as I think we alluded to in the beginning of the presentation, there's a lot of deficiencies in sort of the care pathway for the child services in Malawi. And this next slide I know is quite busy, but I want to just bring your attention to a few areas. This is just mapping out the sort of expected well child care in Malawi at this very moment by looking at the different ages. And if you first look at the visits, you can see that there's actually about 17 visits that are supposed to happen for well child care guidance. But this includes immunization visits, growth monitoring, supplementation of medications like for vitamin A, and even HIV services. So when you actually start looking at these packages and what the patients are getting, there's no real schedule for, especially at the newborn, except for immunizations for well child care and sort of the guidance that's provided to mothers and caregivers. There's no universal hearing or vision screening. And also there's, suboptimal community-based care where there's very few referral systems unless the patients have been referred for very specific things like malnutrition. And then looking a little bit further at 1 to 4 years, usually there's a very good follow-up rate for immunizations. It's between 75 and 85% in Malawi. But once all of the visits of those are completed, which is around 15 months, which even then there's a drop-off in immunization services, it can be really challenging for the patients to follow up for growth monitoring or any sort of further well childcare guidance. So you can see that only about 14% of patients right now who are 12 to 23 months will follow up for these more well childcare visits, and then only about 50% come for deworming and those mass sort of drug screenings as they move forward. There's also a lack of implementation of sort of school health. So despite there being a lot of opportunities for more well childcare in Malawi, it's limited by the lack of resources and sort of availability. However, the World Health Organization and UNICEF have just published, and it's available on their website if you're interested, a full sort of look at the life course of child health, and call it Investing in Our Future. That's the name of the document. And really go through and try to spell out what is the universal and sort of routine well childcare that needs to happen at sort of each of these ages and ranges for children. I think working in the United States or other environments like that, this could be fairly straightforward, but much more difficult to implement in Malawi. And then of course there's more ad hoc visits for acute care and illness, very similar to an emergency room or an A&E, or the integrated management of acute childhood visits. But then there also needs to be referral within the health system and differentiated care for patients who have prematurity or HAE. So this is where I think there's a combination of the pediatric development clinic in the sort of routine well child care, but also the specialized care for especially young children who need physiotherapy, feeding support, and other referrals. So looking at this sort of life course approach and looking at the pediatric development clinic, it's really our job to sort of look with an entire national level team on what's sort of available now and what could be something that we can be working for that could be feasible and acceptable to patients within the resources that are available. So thinking about this in the theory of change, within the Partners in Health sort of vision, and sorry, one of these got a little bit off, but I think at this point we're in the vision of how do we adjust some of the pathways or protocols within the PDC, because it does require a lot of resources. And even so, as Chisomo mentioned, it doesn't have enough resources, even with the more resources it has now. And so in other facilities in Malawi, what are sort of the very basic pieces? Maybe it's, hearing and vision screening, develop at least 1 to 2 developmental assessments, and ability to refer those patients for other services like rehabilitation or physiotherapy if they need it. There's also need for training. And so how can we train existing staff to be able to do some of these services? And how do we sort of cope within their workload as it is? So I think there's a lot of discussion through this task force with UNICEF and WHO on that. That's really looking at how can we optimize some of the care for children using the existing staff. And then there's sort of the influence that we can do. How can we show people what's been able to be done in Neno in a district that's very hard to reach, very rural, has a very impoverished population, through showing some of the pathways and adjustments that have been made through the implementation and sharing, of course, the challenges that already exist. Also, as Chisomo mentioned, there's many models within Malawi, such as the Malawi developmental assessment that's been validated within Malawi or outside of Malawi, of literature and ways that we can also influence some of the work that's being done. For example, Uganda has a pretty amazing developmental screening program that's at the level of village health teams, or community healthcare workers. So how do we start bringing in some of those lessons even outside, the pediatric development clinic? And then the replication aspect would be really working with through technical advising or a role like mine, where I'm sort of positioned even within the Ministry of Health to help think through some of this coordination and logistics and bring people together. And also building coalitions such as donors or funders or implementing partners, or also communities themselves and civil society organizations to make sure that any of these care pathways are really acceptable to all the patients that need them. So some of the next steps to sort of really focus on these areas within the theory of change of how do we bring some of these services to more children in Malawi is this evidence generation for improved outcomes. So right now we're in the process of developing mostly a descriptive, but also an outcome-based manuscript of the first 2 years of implementation within the pediatric development clinic, and also undergoing a costing analysis of that as well to sort of show how much it will cost the healthcare system to implement something like that. We anticipate that cost will be higher than what's available within the healthcare system, but at least we can cost different pieces of it. So again, we can advocate for sort of small pieces like a developmental screen and referral, or hearing screen and referral, for example, to advocate for and showing that at a national level. And then using that work and already the existing data, how can we adjust any sort of implementation of some of these services based off of the national level policies? So again, really thinking about what's feasible now, especially in the well-child visits that are already set up within Malawi. There's been literature that's shown that mothers and caregivers are more likely to bring back their babies to clinics that have sort of more, when they understand like what they're screening for developmental, or if they're also screening for growth monitoring with immunization, for vision and screening. So I think there's already literature on that. And then also thinking about discharge protocols and how do we also differentiate care within the pediatric development clinic, also to advocate for making sure that those most at risk are able to receive care. So I think I've mentioned the collaboration and partnering with, but it's a major point that all of these different partners and teams really need to come in, at the beginning of the thought process of this, and really being able to build it from the ground up. Oftentimes, you can build a really wonderful program, but unless you have that buy-in and that sort of co-development by both health stakeholders, communities, and patients and guardians themselves, it can be very challenging to think about how you sort of scale that or make it most acceptable for patients. So I hope that this gave you some things to think about and an example of well child care and differentiated care in Malawi. And I hope there's enough time for any questions or discussions from this. Our emails are here at the bottom of our thank you slide. So also any questions or sort of follow-up that you might be interested in, please definitely reach out. So I think I'll turn it back over to Teresa to do the questions. Thank you.
Well, thank you guys so much. It's really amazing how much you've accomplished, and I can only imagine that this just kind of scratches the very surface of the need that's there. I wanted to ask you, and you can open up to others to come off mic or off mute and ask questions, or feel free to put it in the chat if you can't. But you guys mentioned that this program initially was started in Rwanda, or was adapted from a similar program in Rwanda. And just as we're thinking about kind of, as you said, next steps and larger national level implementation, what were some of the things that needed to be altered between the program in Rwanda and then contextually kind of updated for Malawi? And then how do those kind of lessons learned impact this next step of nationwide implementation?
Yeah, I think I'll come in and just, so Chisomo, do you want to come?
No, you can start and then I'll just add up to that.
Sure. I think two things, I think one thing in Rwanda that I will say is that they've been able to also implement community-based insurance program. And so through that, they've been able to provide more community-based services. And so I know that they've been able to take up some of the pediatric development clinic aspects, such as developmental screening, into the community. And so they've also sort of been able to sort of pick and choose like some of the really critical things. I think some of the limitations that they've shown is that sometimes those infants, even if they have red flags on development, don't always have the access. Maybe there is services at a hospital, but it's too far. It's very challenging for the parent to get there. And so that while there has been sort of the national scale up, there is required sort of more of these basic, referral based services. But they've also been very successful in doing peer, sort of like mother to mother physiotherapy and sort of developmental play and games to also improve that. So I think that's another part that is just starting and has some implementation in pockets in Malawi. And I think Chisomo can mention some of the work that's been going on in the developmental clinic. But I think that's also, she mentioned in terms of sort of really decentralizing this out and getting it to communities, something that will need to happen over the next, short term. Chisomo, do you want to pop in for that?
Yes, just to add on to that, I think when Rwanda started, they had a lot of infrastructure where they were able to actually implement a lot of more activities than what we are able to do. Like she talked about peer groups, where the mothers were actually having sessions, different sessions, and because of the space that they had, they were able to actually have mothers on the ground doing all those activities, talking, having discussions, which we currently have a challenge to do. And one of the components that Rwanda had actually also initiated is what they call the play therapy for children. And if you go to early childhood development, they are also able to implement that into the PDC while we couldn't because of limitation of space. So we are limited in some areas because they already had structures in place. While when we were replicating the program, we only had a small room where we just wanted to really start the program. But I think from our presentation, we were able to appreciate to say, okay, it's a small room, but look at the numbers that we currently have. So, and they've really advanced quite well in their community program, which is still running. They're able to go to the community, have sessions in the community, not only in the health facility, but actually reach out more to the mothers right there in their own setting. Yeah, thank you very much.
For presenting. I actually I was at the Partners in Health site in Sierra Leone with Joya this summer, so it was really awesome to learn more about Partners in Health. But I was wondering, I think it came up a lot was the role of, or the extent to which the government Ministry of Health is involved, especially I guess in Neno district in this specific clinic, but also, I mean, as you alluded to, as you're scaling up, definitely getting them more involved. Yeah, like what does it look like? Are they, what's the government kind of commitment to developing up the clinic and this model?
So do you want to come in first with sort of the district perspective, and then I can come in on the national?
Thank you. Actually, when it was actually started in the district, it wasn't a welcome program. We really had challenges to really get it off the ground. When you look at children, most of the times we don't really see them as having challenges because they're mostly being attended to by their mothers or their caregivers, unlike an adult where they would actually speak out what they're actually having challenge with. So, but basically when we started PDC, it wasn't welcome in the district. And but when it took off and when the numbers were quite big and being appreciated, that's when it really took ground, and we had some now the DHMT, actually DHMT would now come in and support because they started seeing results from what we were doing. So basically their desire was, oh yeah, we have these problems. Now we have this in place, and this is going to help us work out some of the problems. And because of PDC, that's when we were able to identify that we were having a lot of babies born with asphyxia, which were not actually being supported. And that actually led now to the quality improvement program. Now, because of all these links coming in, it has actually been one of the programs that is being fully supported by the Ministry of Health in Neno. Yeah, so, and they really would want us to train more of their nurses into the developmental assessment, because it has really helped in identifying some of the developmental issues that were actually missed out in some of the areas where children attend services. So currently, I would say our stand is quite good. Only the challenge of space. If we had more space, I would really love to really see that program expanding further. But we are still doing all that we can do in the limited space that we have currently available. Yes, thank you, Deb. Dr. M, you can take it from there.
Sure. I think this is where it gets challenging, because similar to what Chisomo mentioned, I think there is a lot of support between sort of the pediatric organizations and associations, clinical experts, policymakers on the need for improved child, developmental screening and care. But just due to all of the limitations she just mentioned, and also I think, again, there can be a lack of recognition or sort of fear around children, which I think you can see that in any healthcare system if you're not trained in pediatrics. And those, even though it's known and it's being advocated for, those challenge on the ground sort of also challenge the sort of scale up and prioritization of more well child care. So I think, though, over the course of the last 5 to 10 years, there's been an increased awareness and also diagnosis of non-communicable diseases, so congenital disorders, heart disorders, those types of things. And so that's also shedding light on the need for a lot of these services for children. And also sort of rethinking, changing this mindset into this life course approach of, like, if you catch a young girl and you can keep her nourished, well, educated, that's going to have a better effect for her children that she gives birth to, and less likely for her to have a baby with prematurity or birth asphyxia. So also really thinking about it in this generational effects. This is a really good time to push in a policy sense. You can see all those policy like frameworks and things where you need all of these pieces to sort of meet together, I think, for different reasons. One, on a national, international scale, UNICEF and WHO are really pulling together this life course approach and really pushing it. In Malawi, there is this reform around how do we bring all of these disease systems together to take care of them in a patient-centered way. And also there's such things as the Pediatric Development Clinic, and there's some other different screening programs and community programs that have been sort of trialed and learned from. So it's sort of hopefully this perfect storm of opportunity to really at least get some of these very basic screening and care services for children. And it will just take time and more resources, essentially, to really be able to scale up. So it's just that matching of what resources you have, and then sort of the political will and policy level input.
Thank you.
Well, thank you both. I have more questions for you, but I might email you separately. I'm really fascinated by this, and congratulations on all you've accomplished, and as well with this next step. Look forward to hearing how well the national implementation goes, and for your forthcoming manuscript too. Tiffany put a link in the chat, a very brief feedback survey. It's about 3 questions. If we really do appreciate your input and take it to heart every year. So please click on that link and give us feedback. And we appreciate everyone attending, and especially to Emilia and Chisomo for your time today. Thank you, everyone.
Thank you, everyone.